Likewise, copyright. Generally speaking, copyrights are held by human beings too, although they can be held by corporations, but the corporations are basically persons in contemplation of law and owned, certainly, and operated by real, honest-to-goodness human beings. The copyright problem actually is kind of the flip side for AI, at least in the current state of the law as I see it. There are increasing pressures upon AI companies and claims, in fact, that have taken the form of actual lawsuits, alleging that AI is a massive copyright infringer because it gobbles up vast quantities of data from the internet and wherever without paying anything, without even recognizing, acknowledging that it took all this information from everybody else, some of which does indeed enjoy copyright protection. And I will not be surprised to find that there will be some successful claims. That's a guess, and I could easily be wrong, but that's kind of what I see it. Licensure, I'll be quick about this. It is not all that hard to argue that AI offering mental health services, for example, is in some sense practicing psychiatry or psychology or maybe nursing or maybe something else. It is taking highly personal information and making individualized advice to a human being. And by the way, artificial intelligence has no problem passing the USLME and the radiology boards. Those of you who are clinicians in the group may be amused and perhaps find pleasure in knowing that it's also been able to pass a bar exam. So it's pretty smart. Can we then have a license for AI? Well, I don't know. That's kind of an odd thought, but there was a time when corporations were exotic beings. 500 years ago, when it was, or whatever, when it was a brand new idea, there was real doubt about whether a corporation could sue or be sued. I'm here to tell you, here in the United States, home of the litigation capital of the universe, the answer to that is decidedly yes, but it wasn't all that clear back then. What about AI? I don't know. Reimbursement. It is possible, if you're clever enough, I'm not, but if you know how to do it, to take a picture of the back of the eyeball and doctor it up with something known as adversarial noise, which is beyond the capacity of an ordinary mortal to detect, and make that healthy-looking eyeball look like an eyeball with diabetes. You have now greatly increased your probability of getting more compensation for the care of that patient than would have been the case otherwise. It's also possible with manipulating AI, or maybe even without it, to change the diagnosis from something that sounds pretty similar, let's say alcoholic abuse, from alcohol dependence. And by manipulating the data, it's possible to get better reimbursement. It also works the other way. Tom alluded to this. There is currently pending a lawsuit against United Health. It is alleged that because it used algorithms that were faulty in the way they were constructed, that basically United Health has deprived people of care they were entitled to under MA programs that around the country, and that therefore United owes damages to individuals whose care was impeded because of the algorithm that the company was responsible for. A few other general notes, and then I'll call it a day. There's a huge problem with bias. If we have a set of learning data that is geared to weirds, that stands for white, educated, industrialized, rich, and I forget what the D is for. But then there's an awful lot of social science data in particular that comes exactly from that population. There's a real possibility that the conclusion may be valid for that population, but not for the world. Where does that lead us? Leads us into trouble, leads us into opportunities for lawyers, I suspect. There's also the problem of data ownership. Who owns all these data? There's a growing theory that patients own their own data, and that may eventually find its way into the law. Antitrust problems. I don't know anything about antitrust except it's illegal, but there's a real chance that there could be allegations there. And finally, of course, professional unemployment. And they're particularly in the disciplines that rely upon pattern recognition, dermatology, pathology, radiology, real concern that they may be unemployed. You may be pleased to know that there's equal concern in the legal profession that we're going to have computers writing our contracts within the near future. Thanks very much.
Wow. This is good. So let me just bring it back and introduce myself. So absolutely, our theme song should be London's Calling. There's just no doubt about it. I've got to meet these two individuals pre-coming here. My name is Matthew Rumbaugh. I'm the director of telehealth at Gateway Rehab. I actually worked at the University of Mississippi as a regional director, and when our senator was actually in the state office, was coming over to our tele-emergency because Pennsylvania and Mississippi are the same. So I was groundbreaking. I was mentored by Chrissy Henderson. I should be retiring from GE this year, but I shifted gears and got into telemedicine in 2012. So I'm the use case guy, and I'm beating the drum coming from substance use disorder, okay? The Affordable Cares Act over 10 years ago said that we need to treat SUD and OUD like a chronic condition, and we're not, and it's 10 years later. But the reality why I'm up here is we represent a population that need to be treated. And we have technology, AI-driven, remote-driven, that my diabetics in Mississippi, after eating 5 pieces of pecan pie, we were being alerted to tell Maddie to go home, drink some water, and quit showing up in the emergency room. So that Matt started eating only 2 pieces of pie because we built a program around it that we can monitor him with. But we used some AI technology to receive that. We did stuff called branch logic, where they answered how are they feeling, and eventually they figured out how quickly to hit the answers to talk to somebody. But we changed behaviors. I'm gonna blow this up. Think about this. 10 years ago, there was a survey that was put out that said, what was the first thing you did when you got up in the morning? We've been doing it since we've been walking upright. And then they just did that study a year ago. Of the 90% of the people who answered what we normally do, which is go to the bathroom, they answered, checked email. The 20% that didn't answer that said, checked email while in the bathroom. So why I'm doing this to you is we, from this device, have changed a behavioral pattern that is innate in us. So the technology exists to transform. So my use case is to, like I said, London's calling. The reality is I'm up here with a lot of smart people, and we were talking to everybody yesterday. Patients that are truly being monitored, and we can get laws changed and coverage, we have the ability to give a family member and community time to react. Call it augmented intelligence or whatever it may be. So I'm gonna put it in my use case. When my patient falls, he dies. When Matt, the diabetic, trips, his sugars spike. So why can I not be alerted of somebody's respiration dropping? Okay? Somebody's heart rate dropping. Just a little drop that's built into my remote monitoring plan, similar to those that are diabetics, that allow the community to be wrapped into it. And now, welcome to my world, Medicaid. And all we do is check claims data, length of stay, readmission, diversion, and relapse. Antiquated, back 6 months. We're talking about stuff that happened 6 months ago, but now I have the ability to get you in a program where I use AI that allows me to get real-time data and baselines when I'm craving, when I'm looking for something, just to spark something. So on the human side of things, I want to harness the power that we have, utilize it within a responsible manner, because the attorneys will figure it out. Liability, we can write a law for a law, we can get a statute for a statute, and we are going to get to SpaceNet, and it's going to happen. But I don't know one physician in my years in healthcare that will ever rely on AI for a diagnosis. But I'm scared of physicians not utilizing and harnessing the ability of that information to keep the care continuum going. So I hope my use case brings us back to what we need to do here from CTeL is we're marching to get laws passed, the RTM laws. We've got so many things moving forward. But in my arena, SUD and OUD need to be treated like a chronic condition so I can tap into what we have now. The stuff that you all are talking about is downstream for me. So I represent Gateway. I'm super stoked about it. It is a beautiful place. I have a forward-thinking leadership team that's investing and building out an enterprise model. Pre-pandemic, we did this many telehealth visits. Now we have 2,500 encounters a month. We have people on MAT, okay, that are on Butte, not methadone, Butte, that can actually go back home in the community and go to work. And so these flexibilities need to keep being extended, or they do need to be making a decision. But now they have a patient portal, a native app that's a new front door. Now, I do have some heartburn against some of the use cases that's happening right now where you cannot, when you're an SUD or you have this chronic condition, to think that you can go online, meet a doctor, and then be prescribed and think you're going to be okay. That's not going to happen unless you're a professional and you're in lower level of care. But the ability to come in a door, build a hybrid model so that I can follow them back in their community and touch the people who matter, the rural, the urban, remove stigmas, use the technology to change and shape the way we're going to do things. I hope that falls in line to what we're all marching and talking about to get these laws passed and extended. So that's why I was invited. I love this group. But the reality is AI will definitely give me a proactive approach to react to a patient population. But I will not rely on that AI. I will build a whole monitoring pattern around it, just like I do for the diabetics. And if any of you know anybody that struggled with SUD or OUD, if you have private pay, you get to go to your country club. You have Medicare, we got you covered. If you have Medicaid, if you're in my state, you got to go over here. I'm sitting at a table that you said you do emergency rooms. I think these are emergency room doctors. We, during the pandemic, set up Bridge Clinic. They walk in, the doctors know it. They want to treat them, but they've got to stabilize everything. But unfortunately, they want them to go somewhere else, and we set up the ability to capture that patient immediately on a virtual and then get them into inside and treat them all the way down. And that was a Bridge Clinic. So I'm excited of the future of what remote monitoring can do. And anybody who wants to talk SUD with me, or any of the old stuff that we were doing back in 2010, because I feel like it's 2012 all over again. So the opportunity is now to embrace the technology. The lawyers will take care of stuff for us. My doctor said he is prescribing, what type of medicine did you say you're rolling in? The medicine, the psychotropic. Gonna definitely need to monitor that medicine, just like Butte, just like Ozempic. So you're gonna need us to put the monitoring program behind it. So thank you very much, and have a great day. Oh, that's it? Okay.
Are we done? Questions? Comments? Questions? Slink back to our chairs.
We kept that pretty good. We started at 10 after. We got you back on time.
I'm just trying to kick it off. I'll sit back. No, I do have a question though. Have you guys considered the AMA has a taxonomy for AI-enabled devices? And have you guys given that any consideration? Do you think it's positive? Do you think it's limiting? Like any thoughts on that?
I know exactly what you're talking about. I think it's a good start. I think most of the guidance docs that we have out in the world today is just that. It's a good first step. I don't believe we fully appreciate the role that AI will play in healthcare. I'm unsure that any industry has a real good handle on it. And I have a cheeky answer as far as like folks who are trying to figure it out, and forgive me for, it's a bit coarse, so I apologize in mixed company. But throughout my career in telehealth, the adult film industry was prescient in a lot of how technology gets incorporated into society and how we can create economic models that are sustainable. They were the original subscription model that then became Netflix et al. And there are healthcare models that are going to do that. With AI, it's a little bit disturbing about what that same industry is doing with this technology. But if we don't understand the depths of the human condition, I don't see how we discover the heights.
I will resist the temptation to ask my good friend Tom how he happens to know so much about the adult film. But let me say a word about guidance documents. And for this, I am a heretic, and you can burn me at the stake tomorrow morning. I'm against them. Guidance documents have a uniquely powerful capability in the hands of a reasonably talented plaintiff's lawyer to provide excellent cross-examination ammunition. They are written by really smart people with the very best of intentions, and they're always 16, 17 years out of date by the time they get into print. And even this electronic era, we have not solved that problem. And there is one group of experts over here with all the credentials you could possibly hope for, and another equally impressive group over there with an equally impressive array of credentials, all addressing the same question: how do you deal with an elevated PSA, or whatever it might be? And learned group over here says one thing, and learned group over there says another thing, and they don't jibe. And if I'm the doc and I'm looking at this information from these two quarters, which one do I decide to follow? Moreover, lawyers are, after all, in the business of manipulating words. We do that. And no matter how carefully you draft your guidance document, a reasonably capable attorney will figure out a way to take the third sentence in the second paragraph of the 16th page and twist it in a way you never imagined and make you look pretty bad. So I'm not a big fan. They've been used against me numerous times to good effect, or to bad effect from my point of view. So I'm not a big enthusiast.
I have no comment.
Know of in the field, or what you've seen within that space. We were able to develop a diabetes application in 2017 that does use AI, and I think probably most the information is logic driven, but it made an impact in pediatric patients that were determining what to eat, when to eat, and when they should check their A1C and be able to understand what that means. So there was an education component to it that the AI utilized to see what are they searching for when they go into this application. Are they looking for food more, or medication advice? And then it could provide education in regard to that. I think as telemedicine professionals, virtual care, all of that, it's our job to direct and really foster and support the application of it in a very meaningful way for patients that we provide services for. I think it can be very useful if galvanized and directed in the correct ways.
So was that based off of branch logic? Did you have like a branch?
Yes.
So
yes.
A part of
a little
monitoring
both
program for everybody here that knows about remote patient monitoring is you do have to have a resource module for that. From our project that we did at the University of Mississippi, we were getting all the people that were coming through our ER. All of a sudden, we got them onto the monitoring program, utilizing all this, and we saw that they were changing their behaviors. Instead of Matt eating 5 pieces of pecan pie, I ate 3. And I knew that I was going to talk to somebody, but here's what the interesting fact was. They graduated from the program in 6 months. And within the postmortem, we started realizing they were coming back into the door. And we're like, Matt, what are you doing? And that's what caused us to build a diabetes prevention program with the YMCA. But the reality of this was we changed their behavior. Like I teed up with the first thing we did. They felt so connected through the program to somebody that when we turned that off, they felt alone. And then we had to start thinking of it. So the model that you built is based on branch logic, and there are other companies, regression analysis, figure this stuff out, whatever it may be. Predictive analytics, but that was a function, I'm glad that you did, but that's the principles of a monitoring program. But you have to have a complete monitoring program built into it. So emulating what we do for diabetes, you heard me say it. SUD is a chronic condition. If I'm going to use medication, they need to be monitored. And we have the ability through AI to be a little bit more proactive, engage a community, and then utilize what you're saying as far as some of these self-assessments now are we're creating baselines through some AI technology. So keeping it within those guardrails are going to be extremely important. The value is there to support so that I can go back to Medicare Medicaid or the value-based contract and say adherence, compliance, diversion, relapse, death, everything that costs us all kinds of money because you're looking at length of stay, readmission. So this real-time data collection is where I could utilize AI. They are not going to tell my doctor who's looking at me on the video, okay, we're prescribing you Butte, but you're definitely tweaking, okay? Or your heart rate's kicking. What did you do? That doesn't mean we throw them to the wolves, but we're getting to be reactive to them. So I know Krista's looking at me like, but I'm glad you asked that question based on branch logic. We sped up branch logic, because here's what people do. They hit all the buttons to get connected back to us. So we didn't need that because it was killing us. I hope that helps. So thanks for making me feel a part of the team.
Yeah, I couldn't have said it better. Being AI, like any tool, is not a silver bullet. You can't just plug it in. Just like telehealth is not all things to all people in all situations. I have a great many things to say about AI and kids and their interaction with the technology, but that's a conversation for another time. No, not at all, never. Not until you bake your brain, like fully develop it.
Am I the only child of the 60s in this room?